Hello, good evening, everyone. Welcome to my MVF&x and the European Fertility Society. We are back once again, and today we will discuss Dual Stim, which, of course, will be presented by Dr. Elena Santiago. You can see her right here. So, hello, everyone, and thank you, Dr. Santiago, for joining us once again. How are you? Are you ready to discuss this interesting topic? We talked a little bit before we started, and you said that this is something that you use a lot at your clinic. So how are you? Good to have you here.
I'm really well. Thank you. Thanks a lot for having me here again. And yeah, I'm really excited to talk about this topic today because I really like to use it in particular patients. So I'll explain you now all the indications and advantages.
Brilliant. That's great to hear, of course. And just to remind everyone, we will start with the presentation on the topic, but right afterwards, there will be time for your questions. Please put those in the chat, and Dr. Santiago will answer them for you. So don't hesitate. All is anonymous, and of course, it's recorded as well. And let me just remind everyone that Dr. Elena Santiago is the gynecologist fertility specialist at Vida Fertility. So we are happy to have you back. This is not your first event with us, and I'm really, really excited to discuss this topic. And as always, please remember that we are here to see your questions. So don't hesitate, okay? And now I think it's time for our presentation. Let us know if you can see us, hear us, and you can see the presentation as well, right?
Okay, so thanks a lot again for your warming welcome. And well, today we are going to talk about this dual stim topic, which is one of the add-ons that we can use to improve IVF rates. First of all, I wanted to introduce myself so that you can meet the clinic where I work, which is Vida Fertility. We are in Spain. We have two centers in Madrid and Alicante. And we are all very experienced specialists trained for cutting edge techniques. And we are very committed to innovation. We give tailored treatment plans for patients, and we have very dedicated doctor and coordinators for each patient to have a very individual follow-up. Our expertise in remote treatment management gives us also multilingual support to ensure clear communication with all patients. This is the overview of all our treatments. For sure, we are using IVF treatments as well as egg and sperm donation that, as you know, in Spain, maybe it's a little bit easier than in other countries. We do lots of fertility preservation as well, genetical testing, treatment options for single mothers and LGBTQ families. And we are also doing lots of regenerative medicine right now. So to start with the dual stim, I want to explain what it is, and afterwards I will show you a little bit of the theory and the advices when to use it and explain you how it works. So first of all, the dual stim, as the name is telling us, is a double stimulation or 2 rounds of ovarian stimulation for IVF that can be carried out during one single menstrual cycle. The first stimulation is done as always, or nearly always. We start stimulations during a period, so the first days of the cycle, where all we know we're going to have new antral follicles at each ovary. And what we are trying here is that those antral follicles grow with the hormones that we are giving during the stimulation. Then afterwards, we can start right away the second stimulation, which will exactly begin 5 days after the first egg retrieval. This second stimulation is done during the luteal phase of the cycle, meaning that we are starting after ovulation. So for the first round is done in the follicular phase, we call, and the second round during the luteal phase. An egg retrieval is going to be performed after each ovarian stimulation. So it doesn't mean, because sometimes people get confused with this kind of dual stim, they sometimes think that we are doing 2 egg retrievals with only 1 stimulation. No, we're doing just the same for 2 times. 1 stimulation with egg retrieval as normal. After ovulation, as I said, 5 days after the first egg retrieval, we're starting a second ovarian stimulation, which normally is going to be very similar to the first one in terms of medication. We can even use the same. Sometimes maybe we can change a little bit the protocol. It depends on the response of the first cycle. But let's say it's exactly the same again. Ovarian stimulation and egg retrieval whenever things are ready. One thing to take into account, because of the specific luteal phase of the cycle and after having done a previous egg retrieval, is that sometimes during this second stimulation, maybe the patient can have their period during that stimulation, which is not normal during the first phase, but it is normal during the second stimulation. So don't worry about that. Just be advised of it, that it's completely normal, and that's it. So why are we doing this? This is because there's a theory of the follicular maturation cycles, meaning that there is more than one wave of recruitment of new antral follicles during a menstrual cycle. As I said before, we know that in the first days of the cycle, when we are having the period, there's a new recruitment of follicles, and that's why the majority of the stimulation cycles are started at the beginning of the cycle. But we know that probably there are other 2 waves of new follicles that are going to appear. Second wave, it's more or less at the end of the follicular phase, meaning that this wave appears, or these new follicles are going to appear previous to the ovulation. And there is a third wave that occurs after ovulation in that luteal phase that we were talking about. So this explains why starting stimulation at other points of the cycle, so maybe at the end of the follicular phase or during the luteal phase, we can also have a very good response to the stimulation, not only at the start of the cycle or with a period. Apart from all this, it's very important that we understand, and this is something that we normally explain you in lots of the webinars that we are going through, depending on each topic, but obviously it is very important always to understand that women's age and fertility are very important, no? In terms of, as we are older, ovarian reserve and egg quality is going to decrease. And obviously, this means that the chances of pregnancy will decrease proportionally. In this graph, you can see how the ovarian reserve, antral follicle count, and AMH levels decline within age. And on the other hand, the other way around, FSH levels are going to increase within age, because the FSH is like our endogen hormone that stimulates the growth of the follicles. And as we get older, the ovarian reserve is going to be lower, and we do need like a higher dose normally of FSH, so that we can stimulate properly the ovary. And these levels are going to be very high whenever we are in the phase of the menopause, because the ovary is not responding anymore. following this concept of aging, as you know, from the age normally 38, 40 years old, when we do IVF cycles, we do recommend, this is not mandatory, but we do recommend to maybe do PGT-A testing to the embryos, because the percentage of healthy embryos is going to get lower and lower. For example, a woman aged 40 years old, the probability of having healthy embryos is going to be around only 30%. And the patients get older, from 43 years onwards, we are getting only less than 5% of the embryos healthy. So it is important that we select the embryos prior to the transfer so that we can get good pregnancy rates, because if not, the pregnancy rates for each transfer is going to be very, very low. So by doing the PGT-A testing, we are able to achieve, regardless the age, around 65 to 70% pregnancy rates if the embryo that we are transferring is healthy chromosomically. Here also in the graph, you can see how the number of abnormal chromosome embryos is going to increase within age. In the same way, the rate of miscarriage increases because of this. And in the other hand, live birth rates are going to decline as we are older because of this, okay? So very important to take into account the PGT-A testing in IVF cycles whenever we are older than 38, 40 years old. Who is this kind of treatment suitable for? So starting with another important explanation. Whenever we are doing IVF, we know that the more eggs we get, the higher the probability of having a healthy child is going to be. We know that, for example, when getting around 15 eggs, this is going to be like the maximum live birth rate. So the idea would be to get lots of eggs at once with one stimulation. But the problem is that in the majority of patients, and even older, AMH levels or the ovarian reserve is going to be very low. So therefore, the probability of having lots of eggs at once is going to be very low. Even if we stimulate with large dose of hormones, the response is going to depend on the AMH levels and the antral follicle count of each patient. So dual stim is like an approach that we can do for those patients where we predict that the response is not going to be very high, that we have already a low ovarian reserve, that we had a low or poor response to a previous ovarian stimulation, or with that we have a poor egg quality because of age. So in those cases, I do recommend to my patients to go ahead with a double stimulation so that we can get more embryos at once altogether and increase the chances of maybe finding a healthy one for the transfer. Also, those patients that maybe have a normal ovarian reserve, but you've seen that in prior cycles, they have a low number of blastocysts. We can also try and do a double stimulation for our next cycle. Those patients undergoing PGT-A testing, that was why I was explaining before the technique of the PGT-A testing. We recommend maybe to go ahead with double stimulation so that we can achieve a larger number of embryos altogether and therefore increase the chances, as I said, of finding a healthy one. Which treatments can be performed using this double stimulation? So all the treatments for IVF, but without a fresh embryo transfer. Because whenever we are doing the 2 cycles, we are not able to transfer a fresh embryo even after the second round, it's not possible because the endometrium is not going to be synchronized at all to be receptive for that fresh embryo. So the idea of doing a double stimulation is always freezing either the eggs for an egg preservation or the embryos in the cases when we are doing this PGT-A testing. So as we've said, advantages of the double stimulation or the dual stim, we normally are going to get a higher number of eggs altogether in one cycle. We are therefore normally going to get a higher number of embryos. And in this way, we are going to increase the cumulative pregnancy rates because we are going to have more embryos at once. And we are also going to increase the probability of obtaining a healthy embryo for transfer after PGT-A testing. Just imagine a patient where the prognosis is going to be that we're going to maybe achieve only one embryo or two after one stimulation. Obviously, if we do a double stimulation, maybe we can get between 2 to even 4 embryos. And therefore, this is going to increase a lot the probability of having healthy embryos in the end. So, in overall, what are the advantages of a dual stim? So, for all that we've mentioned before, dual stim in the end is going to increase patients' success rates. And the most important part about the dual stim, I think, is that this treatment is very, very well accepted by the majority of patients, as they have a low discontinuation rate compared to stimulation in different menstrual cycles. This means that patients already get the idea of I'm going to do two stimulations all together in one cycle. I'm going to be with a treatment for around 4 weeks' time, and I'm going to get all the possible eggs that we can achieve with these 2 rounds, and therefore all the possible embryos. And it's very well accepted by patients thinking that way. Obviously, if we see that the first stimulation, works out much better than expected, or we have already a very large number of embryos, we are still in time of stopping or not starting the second round. So it is well accepted that if we see that the number of eggs is not very large or the number of embryos is not going to be very high, then we can go ahead with the second round to increase the chances. Take into account as well that another advantage of the dual stim is that we are going to reduce the costs of many patients because we're going to use less medication. We can use the medication that normally is left over from the first round. It's very difficult to always exactly adjust all the medication. We, in the majority of patients, have some medication left over. So this can be used in this second round. If you wait for a couple of months to start a second round, probably this medication that was left over is not valid anymore in the majority of cases because it's already opened and it won't be valid. Okay. Also, take into account that with this dual stim, maybe we need fewer checkups. We are doing 2 egg retrievals in a single treatment, and all biopsy embryos are going to be part of the same treatment. So normally, for example, at our clinic, what we do is that all the pool of embryos is going to be given at the same time to the genetical lab, and therefore we are going to receive the results of all the embryos achieved in the 2 cycles, and this reduces our costs. So this is another advantage for the patients. And fourth advantage is that the scientific studies have shown already there's actual solid evidence of the dual stim where we see that there's no negative effect on the number of eggs. Maybe you can have more or less same response first round or second round. We've also seen that sometimes many patients in a second round have a better response to the stimulation than in the first round. This is something to take into account. Patients also accept very well the dual stim, thinking about maybe second round is going to be a little bit better than the first round. The studies have seen that there are no differences in the fertilization rate or the quality of the embryos, and there's no effect at all as well in the percentage of chromosomical disorders. So it doesn't affect at all to the quality of the eggs or the embryos doing this second round right away. Now I'm going to explain you a little bit how it works step by step. This is the same for a simple IVF, but for the dual stim, it works in the following way. So whenever we contact with a patient, we ask for some tests. For the woman, we need a general health blood test with blood count, coagulation, biochemistry, sexual transmitted diseases, AMH level, TSH, vitamin D, maybe homocysteine as well. We ask them to send us a vaginal ultrasound with an antral follicle count. And we normally ask, this is not mandatory, but before an IVF treatment, we normally ask to have a karyotype. Same for men. If they are participating in the treatment, we need a karyotype from the cells, sexual transmitted diseases, and obviously a sperm test. In women over 40 years old, we normally ask also for a mammogram. Once we have all the results and we've seen together the process, we explain the patient the treatment plan with the medication that we are going to use, when are they going to start doing the first ultrasound, and if everything is all right, then we start with the stimulation. So we need this first normally ultrasound done during the first days of the period, between first, second, or even third day of the cycle. And if everything is good, we start with the first ovarian stimulation. As you know, they're going to take the shots, the hormonal shots, which are subcutaneous, very easy to learn how to do them at home themselves. And then we need to control this ovarian stimulation by doing other ultrasounds, normally around day 5, day 7 of stimulation. And from there, each 2 to 3 days, to monitor the follicle development and hormonal levels. The stimulation normally is going to last around 10 to 14 days. And whenever the follicles achieve a minimum size of between 16 to 18 millimeters and a maximum size of 22 to 24 millimeters, then that's when we are going to give the trigger shot for ovulation. And exactly 36 hours after, we are able to do the egg retrieval. So the first egg retrieval is going to be done normally at the surgery room. In our case, we give a small sedation to the patient. They're going to be with an anesthesiologist by their side. If patients come from abroad, we recommend them to arrive to Madrid or Alicante at least the evening before, so that they come first thing in the morning, fasting to our clinic. And then afterwards, they will be during part of the morning with us, resting a little while, seeing that they're feeling good after the egg retrieval. And we do recommend, if they have to go back to their countries, that they at least stay at the city for 24 hours so that we are sure that there are no complications after the procedure before they take their flight back home. Then, obviously, after the egg retrieval, we can see how many eggs are achieved. And even we can wait a little while, those 5 first days, to see how everything is going on, how many of the eggs have been fertilized, how many embryos seem to achieve the blastocyst stage in that day 5, see how many we are biopsying that same day, or even next day if we have probabilities of doing the biopsy of any other embryos, so that the patients can be aware of the results and decide in the end if they want to go ahead with the second stimulation that 5th day after the egg retrieval or not. I'm going to tell you that I had already many cases even where the first round was unsuccessful. Sometimes we didn't achieve any eggs at all, or we did achieve some eggs, but we haven't had any embryos in day 5 or day 6 at all. And patients did want to go ahead with a second round of stimulation just in case, like let's say last opportunity for them to maybe use their own eggs for an IVF treatment. And in many cases, the majority of cases, I had better results in this second round of stimulation in the luteal phase, meaning that we got eggs and we got even embryos in the majority of patients. So it's just to show you that sometimes it works very good and even better than the first round, depending on each patient. There are also other patients that maybe first round didn't go so bad. We decide to go ahead with the second round to achieve more eggs and embryos. And sometimes second round is not good, or even we have to cancel the treatment. But this is the minimum percentage of patients. In the majority of them, we are going to get more or less similar results as the first round or even better. So when we start with the second ovarian stimulation, in the same way, we are going to perform another ultrasound before we start. This time, we don't need a hormonal blood test. We are going to see, this is very important, that obviously at this point of the treatment, the ovaries are not resting at all. We are going to see ovaries that are larger in size, have lots of follicles from the first stimulation there, but this is completely normal. We just have to make sure that the ovaries are not very large, or that there's not too much free fluid, and obviously that the patient is feeling good to start this second round of stimulation. If there is any sign of, for example, having a light hyperstimulation syndrome, then obviously that's not a good point to get started with another stimulation. In these cases, we stop, wait for the patient to have a period, a normal cycle, and then we will see if later on we need to start again with another stimulation. But let me tell you that in the majority of patients, we are able to start this second round of stimulation because one of the indications was that the ovarian response was not going to be very large in that particular case, or their ovarian stimulation is very low, okay? So if everything is fine, we start again this second round. As I said, maybe we can use the same protocol, or we can even decide to adjust depending on the response of the previous stimulation. If we didn't like how the patient responded to the first stimulation, or we expected a better result, we can always change the protocol. That's not a problem. If we more or less see that the response in the first stimulation has gone as expected, then we can use again same treatment plan or protocol without any problem. So again, we do all the ultrasounds. In this case, maybe there's no need for us to do an ultrasound in the 5th day of stimulation, because still we're going to see very large ovaries, all the follicles from the previous cycle. So maybe even doing an ultrasound in the first days of stimulation, we get confused and we don't know which are the new follicles or the ancient follicles. So even it's better to wait 1 whole week and do the first ultrasound there after 10 days of stimulation and see how things are going. After that, the same as in the previous cycle, we do ultrasound, each 2 to 3 days to see how everything is going on, to again measure the sizes of the follicles and decide the best time for the trigger shot. In this case of the second stimulation in the luteal phase, sometimes it does get a little bit longer than the previous one. So maybe here we are talking about in between 12 to 14, even 16 days of stimulation is normal. But don't worry, we normally get there and everything is good after several days of stimulation to do the trigger shot and another egg retrieval. So what are the conclusions of the dual stim? The indications as we've seen, it could either be for fertility preservation treatments or delayed transfer treatments where we know we are going to always freeze the embryos, normally with a PGT-A testing. This is a strategy for patients, as we've said, low ovarian reserve, poor response to stimulation, and it will allow us to increase the success rates. Not to be overlooked, obviously, that the cost can be lower for patients because of several explanations I given before. Not to be forgotten that dual stim has no influence at all on the quality of the gametes, the quality of the eggs, or the aneuploidy rate. We have same rate of healthy embryos in the first or the second stimulation. And in our experience, as I explained before, we have a very good acceptance of this kind of treatment by the patients. So I hope that these explanations helped you to understand the dual stimulation, where normally it's going to be recommended. And well, as always, thank you so much for your attention. And now I'm completely open to answer all your questions.
Brilliant. Thank you so much for your presentation. I hope you can hear me okay. Just checking because
Yes.
some issues, sorry about it. But yeah, thank you so much indeed. Interesting, definitely. And I know that you have lots of questions, so don't hesitate. Go ahead, type those in. And before we start with your questions, I will give you more time to prepare your questions. I would like to ask you, of course, you've mentioned this, but perhaps, some people are maybe confused. So if you can just tell us what makes dual stim different from the traditional IVF stimulation protocol.
So it's just putting all together 2 stimulations in the same cycle, doing things quicker, let's say, and it allows us to have a larger amount of eggs in one menstrual cycle, and therefore this is going to increase for sure the success rates.
Okay, you've mentioned that, of course, so thanks a lot for reminding us this as well. And of course, many patients are also concerned about the time and how long does a dual stim cycle usually take compared to conventional IVF?
Conventional IVF is normally around 2 weeks.
Mm-hmm.
Dual stim take into account that also we have 5 days in the middle where we are not doing any stimulation after the first egg retrieval. In total, we say it could be around 5 weeks of treatment.
Exactly. Right. So you also need to keep that in mind, yeah, that it definitely takes a bit longer, but as you mentioned, it's definitely worth it. All right, so thanks a lot for that. And one more question from me. So why, if you could explain it, why is this method particularly beneficial for patients with poor ovarian reserve, diminished ovarian reserve?
So it's a tool that allows us to accumulate more embryos. For example, those patients that normally come with more than 40 years, that they want to go through an IVF process with their own eggs, that they already have a very low ovarian reserve. The majority of patients are in this scenario, no? We say, okay, we can try doing a double stimulation in the same cycle to achieve more embryos. And rather than maybe only testing one or two embryos that we could maybe achieve with one round of stimulation, we do two stimulations altogether to achieve perhaps between 2 to 4 embryos, and therefore increase our chances of finding the healthy one. Because also, as I explained before, we have to take into account that the probability of healthy embryo is not going to be very high. So we need normally lots of embryos to at least have one healthy, no?
Right, thank you. That makes sense, of course. Thank you so much indeed. Also, dual steam definitely sound intensive for patients, I'm sure. So how, in your practice, daily practice, how do patients generally tolerate it physically, emotionally, if you can perhaps share that?
So it's true that normally the kind of patients where we recommend the dual steam maybe have gone through already several IVF procedures, so they know how it works. Or maybe if it's for the first time, it's like, let's do this opportunity of doing 2 rounds in one cycle, see what happens. And then if it doesn't work, we will see other options. But it's like putting all that we can all together, no? All the effort, emotional, physical, economical as well, at once, so that we can get the best possible result, and see how it goes. And as I said, sometimes even a first round doesn't work at all, and they go ahead with a second stimulation, and we do achieve eggs or embryos in the second round. So it gives us a little bit more of an opportunity of getting good results, let's say, for the patients.
And this is, of course, the whole point, right? Of course. So thank you so much in that. And, I'm sure there are some common misconceptions that patients have regarding dual steams. Are you able to share anything that can help many people, I'm sure, when it comes to misconceptions about dual steam?
Yeah, so misconceptions, as I said before, for example, is that sometimes they think that the follicles that didn't grow in the first round, that stay small, let's say, are the ones that are going to grow in that second round. And this is not the good concept. The idea is that we are stimulating completely new antral follicles that appear after ovulation. So sometimes they say, are you going to, whenever you are doing the first egg retrieval, are you going to, for example, aspirate only the larger follicles so that the smaller ones are there to be stimulated in the second round? No, this is not the correct concept. We are going to aspirate absolutely everything, and just wait that you will have new follicles appearing after ovulation. Don't worry.
Yeah, perfect. Thank you so much. This is definitely important thing to even repeat, I think. So thank you so much indeed. And finally, before we go for your questions, if you have more, go ahead, type those in. So if someone is watching this today and has been already told that, you have poor ovarian reserve, what would you want this kind of patient to take away from this particular session?
Well, one of the most limiting things that we have no in the world of reproductive medicine is the low ovarian reserve. We are still doing research and trying to find the key to it so that we can increase the chances, because as I said, the most important thing is obviously the quality of the eggs. If sometimes we have one good egg and this is enough to have a good embryo and a pregnancy, and in the majority of cases, if we can achieve several eggs, this is going to give us better chances of achieving at least one good embryo. So for those cases of low ovarian reserve, it is difficult, but sometimes giving you some of the add-ons that we are discussing here in the webinars, such as the Dual Stim, this is the kind of things that can make the difference for this type of patients.
Definitely. Thank you so much indeed for answering my additional questions. We will go for your questions. I'm not sure you are waiting for some answers, so let's go ahead. I have a question from Jane. AMH is 16.2 picomoles, age 40, diagnosis APS, adenomyosis, and endometriosis, lab and excision last month. 2 prior full-term pregnancies, natural, no IVF to date. Trying to conceive a baby 3 after multiple miscarriages, 6 in total. Considering PGT-A, should I require then dual stim? This is the question.
Well, this is the typical case where maybe we need to see how you respond to a first stimulation, because at first your ovarian reserve is not very bad at all. So maybe if you have a good response and we are able to achieve several eggs, more than maybe 8 or 10 in a first round, I don't think that you need a dual stim. I think in this case, it's better to see what we are able to achieve at the lab, how many embryos, do the PGT-A testing for sure. If for whatever reason we see that not so many eggs are achieved after the egg retrieval, or if the quality of the eggs is not very good and we are not able to achieve many embryos in that day 5 after the first round, just be ready, just in that case, to see if you are candidate for this dual stimulation. But I mean, this is not like the typical case where we go for the dual stim
Okay.
from the start.
No, that makes sense. Okay. Again, thank you so much. If there's anything else, James, if you wish to add anything, go ahead, of course, type this in. But thank you so much for answering that first question. And you can see the thank you from Jane, I think. So thanks a lot. Yeah, let's have a look. Yasmina, I would like to, you mentioned this, but I think it's very important to again clarify. Won't double stimulation cause a lot of stress on the ovaries, which might lead to lower response?
So I think it's more legendary to think about this, because as I said, in the majority of patients, I see an even better response than in the first round. It's true that emotionally, physically, sometimes it's difficult to
Okay.
continuously following up this ovarian stimulation throughout 3 to 4, even 5 weeks. But I think that's the most difficult part. Physically, the ovaries are ready. Don't worry. They recover very early after the first egg retrieval. Those follicles, big follicles that we see that are ancient from the first round, begin to disappear, and we start to see the new ones growing little by little. So I don't think it's such a large stress for the ovaries, unless, as I said, that the situation is that you had a very, very good response to the first round, that you are feeling very bloated, that there's like a risk for hyperstimulation. Then obviously in those cases, we don't go ahead and don't start the second round.
Yeah, perfect. That makes sense again. Thank you so much. And actually, there is another question here from Belinda. I will read it for you. Sorry if I missed the explanation, but I'm slightly confused with the dual stim on the second stimulation part. How will there be in many follicles to be seen? Surely won't they be drained out to retrieve the eggs from the first retrieval?
Okay.
Yeah.
Yeah, so sometimes I think it's a little bit difficult to understand this,
Mm,
but as I explained, there are several waves of new antral follicles, at least 3 during the same menstrual cycle. This means that we get complete new antral follicles after ovulation. That's where the second stimulation is going to act, let's say. And don't worry about the first egg retrieval. You can even aspirate the follicles that are around 10 millimeters or even smaller than that, that this is not going to affect the second round of stimulation because new antral follicles are going to appear.
Thank you so much for adding this, because I think it's very important, because that can be sometimes confusing, as we can see. So thanks a lot for repeating that, and I think it's very important to say that and explain. All right, and Anna would like to know, what's the ideal size of follicle that you would proceed with a trigger and an extraction for dual stim?
So more or less the same as in the first round,
Mhm.
minimum having follicles of around 16 to 18 millimeters should be already mature, um, and up to 22, 24 millimeters maximum. So it's normally more or less the same as in the first round.
Okay. Yeah, perfect. Thank you. Belinda also asked, can you do first retrieval and come back to UK and do scans in UK and then again come back to Spain for second retrieval?
For sure, that's the most frequent way of doing things with patients living abroad. That's not a problem at all. The only advice is for you to stay resting the day of the egg retrieval without traveling back home. But the following day, there's no problem at all of you taking a flight, doing the ultrasound back in the UK to see if we get started again or not, and then starting again the medication over there. That's not a problem at all.
Brilliant. So nothing to worry about. This is possible. Thank you. And also another thing from Belinda, have you used Dual Stim on older women like me? I'm 46 with AMH 2.1 picomoles per milliliter, right? Per liter.
Yes, we've tried. Um,
Mhm.
as I remember, I think, yeah, more or less that's the maximum age where we've done normally IVF in general, but also
Mhm.
a dual stim. Um, we could try. It's true that the only advice, Belinda, is that here not only the AMH level is important, also in terms of quality. Sometimes achieving eggs after egg retrieval or obviously embryos is going to be very difficult, but obviously you can try. If you've never tried before, we could always do IVF with a double stimulation and see how it goes. And as I said, if unfortunately it doesn't work, then we will see other
Mhm.
options.
Of course, that makes sense. Again, thank you so much. If there's anything else, go ahead, type those in. I believe that might be our final question for today from Jane. And this is a follow-up. How does Dual Stim work with PGT-A? Should embryos from round 1, right, not be biopsied fresh and sent off, rather than freezing, defrosting, and biopsying them all after the second stimulation? Wondering as regarding stress to embryos with freezing, defrosting, and refreezing. Yeah, if you can explain that.
Yeah, that's a very good question, Jane. Don't worry. What we do is that whenever the embryo in blastocyst stage is ready, either day 5 or day 6, we do the biopsy and then we freeze the embryos. What we can keep at our lab without any problem is the biopsy that we've done. So there's no problem in keeping that waiting for the other embryos to be ready from the second round. And all the biopsies all together will be sent back to the genetical lab. So the embryos are frozen as normal after the biopsy, and there's no need to thaw and biopsy and refreeze. That's not at all the way that we are doing things. Only do it in fresh, do the biopsy, and then freeze the embryos as always.
Definitely, that sounds great. Thank you for reassurance. And someone is typing, so let's give it a minute. Let's make sure. Yeah, I understand now. Thanks. This is the message from Jane. Thank you so much. Glad to see it's clear. And if you have more questions, we still have a few minutes, so go ahead, type those in. If not, we will be finishing. But I do think it was very interesting, important, and informative for sure. So thanks a lot for joining, Dr. Santiago. Any final words?
Well, thanks
Because
a
it looks like
lot.
we will finish.
Yeah, thanks a lot again, as always. I hope that you found it useful, because I believe this is not a very normal way of doing things. Let's say that from my experience, lots of patients, when I talk them about the dual stim, they didn't hear about it at all before.
Right.
So yeah, it's another way of approaching things, trying
Mhm.
our maximum to achieve the best rates, no?
Definitely.
Success
Sounds
rates.
good. One more question. In fact, that we did um, receive. So let me just have a look. Do you use the quicker type of PGT-A testing that I'm reading about? Quicker. I'm not sure, but any thoughts on
Quick
that?
type, I think
No?
it's something. I think that you mean this. Let's see. PGTA testing quicker type maybe is the one
Sorry.
that's in
Sorry,
24
there's a
hours.
message. I think it's called less invasive. So I think that, yeah, this is the
Okay.
case. Okay. If you can
All
explain.
right.
It's non-invasive PGT-A, right? So I'm not sure if you're
Yes.
doing this at the clinic, right? At the moment.
No, we're not doing it at the moment, because we managed to have a very good expertise in doing the biopsy, and in the end, we are not harming the embryos. We don't believe that this is important for the embryos. They are very strong already in the blastocyst stage. We have
Mm-hmm.
a very good survival rate after thawing, even after the biopsy is done. And the thing about the non-invasive PGT is that the results are less efficient. Um, so I believe it's better for now, for the moment, nowadays, to do the biopsy and have better results, no, a better approach of what in reality the chromosomes in the embryo look like. Okay.
Of course. This is like I think that some clinics, of course, do the non-invasive, but it's still like a trial still. So it's not like it's available everywhere. So you need to keep that in mind as well, right? So thank you.
Yes.
Thank you for the clarification. Thanks a lot for sure. One more thing in the meantime, dual stim, is it necessary for someone who is 44? This is the question.
I mean, probably yes. It depends on your ovarian reserve. If you have a very, very good ovarian reserve, and we predict that the response to the stimulation is going to be very good in terms of having at least 8 eggs, for example, then maybe it's not needed. But in the majority of cases, as the ovarian reserve normally is low, then yeah, I will probably recommend it, so that we can get several embryos all together and increase our chances of finding the healthy one after
Yeah.
the PGT-A testing.
We did receive the message AMA 0.5, not sure nanograms or picomoles, but this is the information we got. Anything
Okay,
else?
in either of the units, AMH 0.5 is already low, then yes, I will recommend for sure the dual stim
Mhm.
to be done.
Sure, that sounds good. Thank you so much. And of course, we will be finishing for today. However, of course, remember, if you have more questions, we'll be happy to answer them. So you can simply join our next event that we are going to have tomorrow, actually. And it actually we will discuss low ovarian reserve. So again, I think it will be connected. So you can definitely join us tomorrow at 7 p.m. London time, of course. But also, we will be happy to get any questions from you, we will be happy to forward those to Dr. Santiago and her team at Vida Fertility. So feel free to do that. Thank you so much, everyone, for joining us today. It was very informative. Dr. Santiago, thank you so much. It was lovely to have you back. Of course, we will have more events with you. I'm really looking forward to it. So thank you,
Thank you,
everyone, for
Caroline.
joining. It's always a pleasure to have you. And of course, thanks for your questions. Thank you for participating. And of course, we will be back with some more events. So stay tuned. Thank you so much. Take care. Have a good night. Bye.
Thank you.
Bye.
Bye bye. You too. Bye. Thank you.